think I've gotten it now. All right. So, like I was saying, that labor work prioritization is like a compulsory case, and I think the mistake that I made initially when I was preparing for this exam was I think I was focusing more about the other stations. For example, let's say Euro Guinea, you don't know what will come out, although you have an idea of the cases that might come. But for liberal prioritization, you know that definitely this is going to come out. So all you needed to do is to like revise all the possible labor ward scenarios and how you are going to tackle all of them. The other problem with this labor ward prioritization is that there's tendency for you to just you want to say everything because you see a case of preeclampsia, you want to talk about how you are going to manage and everything. But what you should realize is that this labor ward prioritization, there are certain things they want you to just do, okay, which is to first ask more information, delegate the task, prioritize, and then you say what you feel the person should do. Or if you are the one taking the case, then you say what you are supposed to do. Okay, so you are not really supposed to mention everything because for like the first Dr. Kazi, I was looking at my time, and by the time you finish that number seven, you had like 6 minutes left. So there's no way, I knew that there's no way you're going to finish that labor prioritization if you spend close to 4 minutes on a question. So, in as much as you have a lot of knowledge, the skill you need to learn here is how to summarize what you are supposed to say so that you will be able to finish the station well. Okay. People are still trying to join. Okay, so if we just talk about the key points, so first thing is situation awareness. So situation awareness, what I mean by this is that if you look at the question, they are going to tell you where you are. Let's just go back. Okay, so they say you're working in a maternity unit, then the time. So, okay, let's just, so where you are also matters. So if I remember the November exam, what they said was you are working in a maternity unit with a level 3 neonatal facility. So when they said level 3 and available cot, so when you get to those, there's a station here with preterm labor. So already in the question, they already you are already informed that you have a level 3 neonatal unit and available cot. So in that case, I also made a mistake. I asked them like, are there cots available? And then the examiner said, yes, is in the question. So that shows your situational awareness that you need to be aware of the information that has been given, and there's no point asking again because you're only wasting um, your time. Other thing about situational awareness is the timing. So they will tell you that when you are receiving the handover. Why this is important is because there might be a patient that you need to repeat vaginal examination. There might be a station that they will say that maybe last vaginal examination was 4 a.m., for example. So if it's 4 a.m., it means the woman is due to be examined again. Okay. So, but if you are not aware of the time that you are taking over the shift, then you might miss that. Okay, then the other thing is who are the people working with you? So you have to know who are those working with you. Here we have ST2, ST5 anesthetists, and then you have band 7 midwife and 5 other band 6 midwives. We'll briefly talk about these midwives very soon. Okay, so if you have all of these, then you know their competency so that you'll be able to assign the task appropriately. So the next thing is when you are doing the summary, you should use this SBAR tools, situation background assessment, and then recommendation. So you don't have to, pardon me, you don't have to read all the information that are given in the case because I think that will only waste your time. Okay, so for example, this number one, if you want to summarize, is a case of spontaneous rupture of membrane, spontaneous rupture of membrane. So that is the situation. Okay. So what is the background? She has had previous CS for placenta previa. So why they only put placenta previa, because you know that is not a recurring indication. Okay. So it is case of spontaneous rupture of membrane at 39 weeks in a woman with one previous CS. So if you say that, I think you've done your summary. So you now ask. So next thing is to ask what are the additional information you want to know. Okay, and then you continue like that. You do your priority. So you should never prioritize until you have asked more information. So you prioritize, and then you delegate the task, and then what the person is supposed to say. Hope I'm making sense so far. Hope I'm audible as well. Hello. Hello. Can somebody respond? Sorry, I don't like just talking and talking.
Yeah, we are with you, Dr. Sini. Please
Okay,
carry on. Yeah.
okay. Thank you for the feedback. All right, so we've talked about using this S bar to so now you have the option of going room by room or otherwise. I would say I prefer to do otherwise. Otherwise here means that okay, do you want to just talk about the urgent cases first before you then talk about the other ones? Because the risk is that if you look at this particular labor ward prioritization station, uh, the most urgent case seems to be number nine. So if you decide to go room by room, and let's say you got to number seven or number eight, and time your time got exhausted, it means that you don't get to talk about like the most urgent or high priority case. And in that case, I'm not sure if the candidates will be able to pass that station, because I mean, from the updates caused by RCOG, what they said is, one of the examiner, what he said was, if you do that kind of thing and you ended up not talking about the most urgent case, then it's likely that the person will not pass that station. So yes, you can prioritize with that additional information, but in that your 2 minutes, when you are scanning through the cases, you have an idea of which ones are likely going to be the top priority. So you can ask further information about those ones, and once they tell you, the ones they give you information, patient is hypotensive, still bleeding, then you know that's the most urgent one. Talk about it, and then you can now start doing room by room. I think that's what the second candidate did, which was impressive. Okay, so that's what I meant by that. Then ask for more details. I think I've already spoken about that. And then don't forget to prioritize in when the whole essence of the station is labor prioritization. So sometimes you might be carried away, and you just say, okay, I'll delegate the task to this person, they will do this, they will do that. But you still need to prioritize. So now, I know some people said semi-urgent. I think both of you use that terminology, right? Kazi and Sabina.
Yes, high priority and urgent, semi-urgent.
Okay, so I think what the caller says is like there's no midway between the two. So is either the case is urgent or non-urgent? Because I could remember when I also mentioned something like that in the course and in the RCOG course. So what they said was, is that the case is urgent or non-urgent? Because what is the definition of being semi-urgent? So if it's urgent, when you say it's urgent, it means that you need to do something right away. either to save the woman or the baby, something like that. And if it's non-urgent, it means there is no threat to the woman or the baby at that particular period of time. So I think they'll prefer you to use urgent or non-urgent. I hope that is clear. And then call for help, which I think you did, especially for the urgent or high priority cases. You need to call for your senior, the MDT. We'll briefly still talk more about them. Uh, so assign tasks to colleagues appropriately. Yeah, we've talked about that. Excuse me. Then avoid undermining. So what I mean here is that avoid undermining. If you look at it, that you had like band 6, band 7 midwives, which they're actually senior midwives. They are very good. So you should know what they can do and should not undermine them. The other example is that there are some liberal prioritization cases in which maybe the patient is in a midwifery led unit, MLU. So then in that case, maybe the when you ask more information, they might tell you that maybe there is fetal tachycardia or fetal heart rate abnormality. So you need to find like a, how will I put it? You need to move the patient from midwifery-led unit to a consultant-led unit. So you have to find a way to say this without undermining the midwifery-led unit. Okay, so just something like that. Then neonatal unit availability, we've already spoken about that. And ensuring safety of other patients. This one comes in if, for example, you needed to go to theater. What's that? So if you need to go to theater, and then sorry, it's like I was drinking. So if you need to go to theater and then you still have other patients on ground, so that way you need to find a just say that like you ensure safety of other patients. So you like take a panoramic view, open that okay, hope no other patients safety is at risk. The fact that you are going to theater, okay. So having said all of this, um, we'll just talk briefly about the team members and their competencies. So what can each person do? I know this is not an exhaustive list, but it's just like a summary. So when we say senior house officer, so that includes the ST1 and ST2. Okay. So ST1 can take history, examine, can do manual removal of placenta, but after they have achieved competency, before they can achieve competency in any procedure, they will need to do summative OSAT. They would have that's 3 summative OSAT, in which one of them must have been signed off by a consultant. So it means if they have achieved that competency, then if a patient needs a non-rotational instrumental delivery, then you can delegate that task to them. I hope that makes sense. Then ST2 can do what ST1 can do, in addition to these other things. They can suture episiotomy without supervision, interpret CTG, and inform. So they inform the senior colleague. They won't act on it, they will inform. And then they can obtain consent, and then they can do uncomplicated cesarean section, but a senior has to be with them to assist them. So we have ST3 and ST4. They can do non-rotational instrumental delivery. They can do uncomplicated CS without supervision. Okay, and then they can repair third and fourth degree tears under supervision. Then for the advanced trainee, this one can repair third and fourth degree. So this is where you usually the question will say you are the ST5. Okay, so you'll be able to do all of this. And then for band 7, the nurses and midwives in the UK, their own grade is in bands. So you have like band five is like the is like a staff nurse or like the entry point. Okay, band six is when they are like band seven is not specialist, like a specialist, so to say. So they are senior midwives. Okay, so labor ward coordinator will likely be like band seven. Okay, so and they can do all of this. So now, I'm sure I won't spend time. It's just for people who are not in the UK, or just to refresh our memory. This is how the training goes in the UK. Foundation year one and two is just like housemanship or internship. Okay, then if you get into training, you get the national training number, and then the training goes this way. Okay. So now, going back to our stations, I hope we'll finish before half 11. All right. So number one, um, or do we just? I think we should just do room by room, right? Or we should go the way I mentioned earlier. Let's go to like the most urgent one first. So number nine. So number nine is a woman who has just had delivery of a macrosomic baby and then developed postpartum hemorrhage about 1,500 mils. Okay, placenta has been delivered. So additional information. You did ask Dr. Sabina, but I think you could have just asked me what are the observations, because you're asking me bit by bit. What is the blood pressure? What is the saturation? What is the pulse? So I think if you just
Because
ask
I
me,
asked one by one, because on a RCUG course, when I asked, different together, and he said that no, I didn't remember all those things. You need to ask, one by one. I'm not going to giving you if you ask the observation.
oh, that if you ask observation, right?
Yeah, like specifically, and he said that not to ask too many in a one time. I am not going to giving you. So
Yeah.
ask specifically blood pressure, pulse, set like this.
Okay.
That what you want.
Okay. Maybe that's what they want then. If I Dr. Kazi, I remember she mentioned like four things together. Like I want to know observation, what's the exam, abdominal exam, PV, something like that. I know that one is not acceptable. You cannot ask like observation, abdominal examination, VE, CTG. So you can't lump everything together. But
But the thing is, I have a comment here. So if we ask like what is pulse, what is blood pressure, then what is the abdominal findings? Like if what is the contraction, three out like how
No,
many
no,
out of
not
10?
not like what
yeah,
is
Like
what
that?
is. Not like what is. Just say pulse, BP, sat,
Yeah. So
contraction
we
like
we
this
cannot
very
finish within
quickly.
10 minutes actually. Most of the task it will not be finished. Maybe three or four station we
yeah,
can finish at that time. We tried before this way, but
yeah.
it never finished within this. Like if we ask like pulse, blood pressure, then the examiner will think and give something. So previously we tried this, but it is not happening. This is
Yeah,
the one concern.
okay.
Yeah, we need your
Yeah,
suggestion about that also.
yeah, I know. So I don't know who what Dr. Sabina, but in my own exam, what I did was what is the patient observation? And then the examiner gave me the pulse, blood pressure, saturation, temperature. So I didn't have to ask, because that will waste time, so to say, if you start asking pulse, BP, this. So I don't know, maybe it's just the examiner's
Yeah.
difference.
Yes,
Maybe
yes. It may be different based
yeah,
on their
maybe you
expectation.
don't feel
Maybe yes.
comfortable. But I think most people would give you it, this. The other thing is, if you don't ask, don't say what is the vital sign. I think somebody also mentioned that vital sign, they don't like, they tend to call it more observations than vital signs. I know some of us in our home countries, we used vital signs, including myself, but just have to learn the term that they use. So just say what are the observations, and I think at least 80 to 90% of the time they are going to give you the observation. The only one, if you say what are the observation, what is the abdominal examination, what is VE, then that one you are like lumping so many things together, and they will not answer you. So if you ask what is the observation, they tell you what is how about abdominal examination findings, they will tell you vaginal examination. Do you get? So what you want to know is in each station, depending on the scenario, you might want to find out one or two questions from the history. So apparently this patient now, the already said she's bleeding 1,500 mils. Okay. So I think what you just need to know is the observation. What is the abdominal examination findings? Because you want to know whether uterus is atonic or well contracted, as that will guide you on the possible cause of the PPH. Then you want to know vaginal examination findings. So there they will tell you whether she's still, if the bleeding is still continuous or not. If it's a labor case, just say what is the VE findings. So instead of saying what is the dilatation, what is the station, something like that. So once you say what is the PV or what is the VE findings, they will tell you exactly the information that are available, the dilatation, the station, and other information that way. And then there are some stations that you may also need to ask for investigation. So you want to know if it's a woman that is in labor, what is CTG? Then if it's postpartum patient, for example, you could ask any investigation done like full blood count, because some cases they might have done a full blood count and they will tell you maybe hemoglobin is 7 or hemoglobin is 6, for example. So it just depends on the scenario, and that will determine what additional information you need. Okay,
So
now
for
so once, sorry.
sorry to interrupt, sir. So for the investigation, we have to ask specifically, right? Otherwise, they will not give this
Yeah, they will
investigation.
not. Yeah, they will not give, because in this case of bleeding, the most important thing you want to find out is hemoglobin. So you can say what
Hemoglobin,
is
yeah.
the complete blood count or what is the full blood count.
So
Then
I have to ask specifically that what is the hemoglobin, right?
yeah. So, but I think I would just say what is the full blood count. You know, hemoglobin is under full blood count in case they have
Yeah,
platelet or whatever. But
yeah, yeah. Mm.
so just say what is the complete blood count or what is the full blood count. Then if it's only
Mhm.
hemoglobin they have, they will give you. If it's PCV, they will give you. If it's platelet or other things. So that's that. So after that, then you should do the prioritization. So it's any case that is urgent, then you have to go. So if it's urgent, you go and then involve the MDT. So involve your consultant, the even anesthetist, you go with the ST5 or even the consultant sometimes, and then other people you involve, intensivist, hematologist. Okay. So the other problem is not trying to say everything about postpartum hemorrhage. Okay, because you know there is a whole document on a guideline on PPH. So if you decide to, say everything, it's possible that you may not be able to finish. So yes, you press the emergency, the border, you activate the PPH protocol. So when you say you activate the protocol, then you are speaking the right language. We all know what is under the protocol. I think you just briefly mentioned few things about it. Yes, you establish another IV access because they said she's already on syntocinon infusion. That means she has one IV access. So establish another access, take investigations, list them, full blood count, use and ease, LFT, coagulation profile, group and cross match. I think somebody mentioned group and save. So if it's PPH, then it has to be group and cross match. Okay. Then you resuscitate the woman following ABC. So you don't need to mention I don't think you need to mention details because you may not be able to finish. So resuscitate the woman. Okay. Then you transfer to the OT for EUA to check for. They said she had a large second degree episiotomy that is repaired, but she's still bleeding. So it's possible that might be a cause. And also, if you look at it, it's macrosomic baby, so risk of genital tract laceration as well as atony. So two things you are targeting in this woman. The placenta has already been delivered, so it could be genital tract laceration and it could be atony. Because if you also look at this information, atonic uterus with active PV loss, so you need to check for both. Okay, so pass a catheter so that you are monitoring the urinary output because of PPH, and it will also help with uterine contraction. So now this woman has already had first line of oxytocin, so you can give second line oxytocin. Okay, and then consider tranexamic acid. And then for the atony, she might need intrauterine balloon tamponade or stepwise surgical or results to surgical procedure. And then I think you should also mention that early recourse to hysterectomy is also important. So I think with that, in 2 minutes, you should be able to say all of those things. If you just highlight them that way, instead of you want to say, okay, resuscitate, I will give crystalloid, I will give colloid, 3.5 liters, things like that. So it's only if you have like, if that's the only if PPH comes as a standalone station, then you may have to expatiate on all those things. But if it comes as labor prioritization, you just need to make it brief as possible. Any questions? Should we move to another one? Hello?
No questions, just incident form needs to be filled up at the end. SDU, and you have already mentioned an incident and debrief. That's all.
Yeah.
For the patient safety point,
Yeah,
they will mention the
1,500.
incident.
Yeah. Yeah, you need to do incident reports. Of course, uh, patient will need to be managed in the HDU after the surgery. Okay. Uh, Number 7, I think there was some confusion here. So if you look at the question, I just wanted to talk about it before we now start from number 1, since we've dealt with the most urgent case. So this case says that the patient is coming in by ambulance. So when I think somebody asked for additional information, I, t- I told you that our patient is still on the way and no information, examination, or vital sign or observations are available at the moment. So in that case, so what you can say is that, because I think we did this station too in the RCOG course. So what they said was, because patient is not yet in the emergency, so you could say that, okay, for now you delegate. It looks like it's urgent, but because patient is not around, you would delegate the case to a midwife, so that like senior midwife, so that once the patient comes, they can attend to them, establish IV access, take samples for investigations, and then they are going to inform you. So once the patient now comes, that is when you now go. So you don't need to mention all the other things you will do, because it's just patient is not even on ground yet. You don't have any additional information, like you don't know the blood pressure, you don't know whether it's severe preeclampsia or not. All you had was just that information. Okay, so I think that's how they said you could approach the station, so you don't have to spend a lot of time in that number 7 actually. Okay, so you could mention your differential, like, yes, headaches, vaginal bleeding. It could be case of antepartum. Is a case of antepartum hemorrhage because of the headache. Could also be severe preeclampsia. But all of this you don't know yet. You don't know the blood pressure. You don't know urinalysis. You don't know if it's abruption or not. So that's just how you tackle it and just move on. Okay. So if you then go, let's go to number one. Then I think we've dealt with the
Can
seemingly
I ask one question here?
yeah, sure.
Sorry for that. Room number 7. Is it the real task in the exam? Because I think if she's coming through the ambulance, this sentence was not so clear for me, and as I could not see the room number 9. So apart from this, if I cut out the room number 9 fully, so that is the thing. So it was not clear that she is still in the ambulance. So I was thinking like she's coming with the ambulance and she's coming in, like she's entering into like that. So
Yeah.
it's supposed to like that for me. And when I asked another information, like I'm just asking, so if she's coming through the ambulance, I think there should be someone with her escorting, and they should have checked the blood pressure. So why there is no information and we can actually communicate with them, why I will allow the patient is coming and no blood pressure measurement in the ambulance also it can be done. So that is like I'm asking to know. In that
Yeah,
case, the blood pressure machine should be available there, right?
yeah, it's a real question. So what I don't know if you asked me for additional information. I think Sabina
Yeah,
asked me.
I asked, yes,
Okay.
yes, I asked,
So
and you
I,
mentioned that
I
there is
didn't
no
ask you.
additional
I didn't
information.
ask you any additional information
yeah,
because
I
you
know
know that
somebody asked the
he
other
is
person did not know.
on a ambulance. I think this is the practical things what's happened here. Even though you know that patient is coming by blue light ambulance, but you would be quite surprised when she come. There would be
Mm.
no
Mm.
like a minimal headache, no raised blood pressure, nothing. That is why they given it to us. That see
Yeah,
that if the examiner said that no information yet, so that's done.
yeah, that's
So
it.
that's done. That we need to just the midwife can taking care. What is usually happen in UK? The midwife will taking care, take the blood pressure and all those. If any emergency, they will call us
Mm. Blood
Exactly.
pressure
So
can be
because
measured, right, in the ambulance?
there is a hierarchy escalation in place. Anyone
Oh.
come by a ambulance, midwife will see first. If any problem, they will immediately escalate this one to the senior and last to us. So there is a system available.
yeah, thank
No,
you
my
very much.
question was not there actually. I was I'm thinking that my question was not clear for me. Sorry for that. I was asking like, is
No,
it available that during the ambulance escorted, so that time the
yeah,
blood pressure can be monitored, right? At least.
yes, yes.
And
So, but
like I'm asking actually just to know if the blood pressure is high and whether like if pregnant lady is coming, so there should be something. If they could not start the IV labetalol itself, but they could start some oral medication for the blood pressure. So that is like actually I'm asking.
yeah, so I think you shouldn't bother yourself about information that is
If
not
it is,
available.
yeah, yeah. So that is
So
my
you shouldn't.
asking actually. So if I am the in charge there in the labor ward, and if I
Mhm.
know about this case, so there that should be my duty to inform that who is escorting her and who is available there to tell them to measure the blood pressure and let me know if the blood pressure is high. I could say over phone. It should be logical. I should not allow 30 minutes there in the road and then the developing high pressure, high blood pressure and coming with the
Um,
eclampsia inside. So that is my asking. I think that should
But
not be logical actually.
sorry, I just telling you, this is the labor ward board, and you have very serious patient on there. You need to see whole board panoramic view. That who is the
Yeah,
important
that
in
is also
front
my
of me
patient. As
now.
it is
So
available in the labor board,
she is the
that is
least
my
one.
patient also. Yeah, I should not allow her to be eclamptic
No,
until
it's not that
like,
we should not
No,
allow. This is the things that there is the ambulance people have monitoring the blood pressure and everything. And in UK, it's not like a long time, like an hour to come. It's very quickly because they should be go very quickest hospital they could. So there is a safety net available. It's not that me that my consultant is responsible for this. But we have a patient who is too many patient as a register when I'm on call. I shouldn't be bothered by if anyone told me that, no observation needed. When she come, we'll deal with that. We need to do the other people's taking care first.
yeah.
yeah, I
So,
got your point.
is it
Thank you
clear
for your
now?
input. I
Is
was
it
But
just
if
clear now?
anyone
asking that
come with a ruptured, abruption placenta,
no, no,
there
Sabina,
is
Dr.
a code
Sabina, I
one
have
straight
got your
away.
point. Sabina,
Ambulance to theater, code one, ambulance to theater. That's happened also.
no, no, I have
I
actually
think
I have
she's
got your
gotten your
point.
point now,
I was
Sabina.
just asking that is it okay to tell the ambulance people to give the oral medication itself to
No, no,
them
no. Ambulance
if the
people are
hypertension
not
or no?
obstetrician. No, they can't. They are not obstetrician.
No.
No,
It's
no.
not
I am
safe.
asking, is as it is available in my labor board, is it the responsibility for me to know about the vitals and tell them anything in the way? So that was my question itself.
Hold
I
on,
think
hold
my
on.
question was not clear for you. I think, yeah.
I, I don't know. I don't know what what your question is actually about. So, but the summary is that, you know, if a patient is coming, from the ambulance, let's even talk about, for the exam purpose, and Sabina has also tried to relate it to real life. If they tell you don't have additional information, I don't think you should bother yourself and not assume that patient has high blood pressure and start talking about it. Just move on. This even not only labor prioritization, any case that maybe structured
Yes.
this or anything, if they tell you that there's no additional information, I think you should just move on. It means there's nothing more for you to explore in that direction.
Otherwise, the examiner will think that you are not awareness of the situation, because there are 9 room, and
Yeah,
one by one there is so poorly patient, and I'm just thinking about that what's going on the ambulance. If she said that
yes.
no, 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 nothing is available, when she come, we will be deal with that.
Yeah, yeah. Okay, thank you. Thank you
Thank
for
you for
coming.
the nice discussion.
Let's
Yeah, thank you.
let's
Okay.
let's go on.
Yeah.
All right, so hopefully we should finish by half 11 because I've got to go to work. All right, where are we? We've talked about so I think we are on number one at the moment. Okay, so number one case, I think I mentioned about the summary earlier, then additional information. Yeah, I think Sabina asked, which I gave. So this case is actually like a dicey situation. She's ruptured membrane for more than 24 hours. She doesn't want any medical intervention. Okay, and is one previous CS. So as it is, you might actually need to go to this case yourself, even though it's non-urgent for now. No sign of infection. Observations are normal. Not really contracted this 1 p.m. So CTG is normal. So there's nothing that looks like it is urgent for now. So it's not urgent. But because this patient needs a lot of counseling, so first establish IV access. You should take samples to rule out infection. But as it is more than 24 hours, we actually need to start on antibiotics, and then you need to counsel the patient about the option of conservative or intervening. So conservative means you can tell her that most women within 24 to 48 hours they will actually fall in labor. So if she chose that, that's okay. But you need to also tell her the risk of infection that might come with it. And you're trying to minimize that with use of antibiotics, and then continue to monitor her vital signs and CTG as well. And then the other option might be mechanical method of induction, like Foley catheter. But this patient says she doesn't want any medical intervention. So you need, in that case, you then need to inform your consultant and let it be like a shared decision making between the woman and the consultant as well. So
Because she is Shrom, she should not be have the Foley's catheter. It's a contraindication, Shrom.
yeah, yeah, the risk is risk of infection, right? But if you give antibiotics, you might consider it, and that's why I said it's not the decision you take at your level. So inform the consultant, and then let them discuss with the woman the pros and cons of watchful waiting, that's conservative, and the medical. So and then she can decide which one she would like to have. Okay. All right. So number two, I think that one is just straightforward. Is an empty room. The coordinating midwife will arrange for any cases that are waiting to be um, admitted. Okay. So number three, I think you guys did this one quite well. You asked for additional information, which I gave. I think one person didn't ask if courts are available, but I later gave the information. So you should always ask because I think it's preterm, right? 35 weeks. Yeah, even though it's late preterm, but it's still preterm. So you should still have that information with you. So everything seems to be good. So you should aim for vaginal delivery, but in this case, you should secure IV access and group and save because risk of PPH, continuous monitoring of the woman, and after delivery of the first twin, there should be a portable scan in the room um, to scan. So if the ST2 is competent, they should be able to scan the second baby to check the lie and presentation. So if you still remain transverse lie, um, there are options that can be done. If membrane is intact, not contracting, you could do ECV and do you could do ACV, or there's an option of doing assisted vaginal breech delivery. Okay, then don't forget to mention active management of third stage of labor because the woman is at increased risk of PPH. Then number five, what is this case? Okay, so I can't even remember if yeah, I think you asked for addition. Both of you asked for additional. No, only one person did this. Additional information. Then take baseline full blood counts and then eye vaginal swab to screen for infection. Should do a speculum examination to check if there are any cervical changes. And because of the PV discharge for a week, so you want to rule out that she's having prom or not. So if she's having prom or established preterm labor, then you know you have to consider removal of the cerclage, as either of those is an indication for cerclage removal. And then you should also consider antibiotics cover. How long can she be having discharge? Yeah, for a week. So, and then if in established preterm labor, steroid, magnesium sulfate, and then apparently you have to inform the neonatal team as well. So I think um I think Sabina answered this and she did well. Number six is a case of undiagnosed breech presentation. I think both of you did this. It was all right. You asked for VE. It was so. Look at this case, for example, VE at 4 a.m. It was 2 cm dilated. So, what do you think we should do now?
Quick
Hello.
examination again.
Yeah, so she's due for another
Mhm.
examination. So you want to find out, you
Mhm.
need to do another PV. That's situation awareness. So know what dilatation it is now. She need a bedside a scan to rule out any contraindications to vaginal delivery. So I know you guys were trying to mention all of them, but it might take time. So, but if you mention something like that, that you need to do a scan to be sure there are no contraindications to vaginal delivery. So that's like an encompassing word for whether is the neck is hyperextended, whether the weight is below 10th centile or more than 3.8, something like that. Okay. Then you need to counsel the woman about the options. So she could have cesarean section or vaginal delivery and just counsel about the pros and cons and let it be an informed shared decision, and then you move on. So number seven, we've talked about that. Number eight, this is a woman who shrugged strong with drainage of meconium stain liquor at 39 weeks. Okay, so additional information given CTG normal, PV at 7:30, now it's 8:30. Okay, so you're not repeating that yet. It's 2 cm cervix presentation, head is still high. So is it urgent or non-urgent? Anybody?
This is the, meconium stain is the urgent case. It shouldn't be non-urgent. Anyone in a labor, early labor with a meconium, urgent case, but not the high priority.
You say it's urgent but not high priority. Okay. Well, if you say it's not high priority, that means it's low priority, right? I think because
It's urgent. Anyone in a labor meconium, 42 years, is an urgent case, but not like the room number 9.
so if you say it's urgent, doesn't mean you are going to go there. Remember, you're already attending to number 9.
No, all urgent cases we don't need to go. We can prioritize, delegate the things.
Okay, so who will go
May I
to
comment on this case, please?
number 8? Yeah,
Yes,
I
number
agree with
8.
you. If it's looking like in between the two, then you should go with the higher priority, so to say. So if it looks like is it urgent, is it not urgent? If you are not very sure, then you should say it is urgent actually. So that way it
Mhm.
means that you are like on top of the game. So not you are not really dismissing it. So I think in this case, because you are busy, your ST2 and midwife can actually see the patient as well. Okay,
Mhm.
so they can take the samples, let the CTG continue to run, and then you need to examine her 4 hours from the last examination and see what she is. So, um, if in active labor, you could observe. So, there it was 2 cm, which is still latent phase. So, you want to see if the labor is progressing. But if she's not in active labor, then you might consider um, induction after counseling the woman and then consider her wishes as well. And then because it's meconium stain, baby is at risk of meconium aspiration. So you need to inform the neonatal team as well so that they will be well prepared and then be able to manage the baby and then also inform your consultant. So that is all. Do we have any question?
Are you done?
Almost. Hello, any question?
No, I don't have any question.
All right.
Hello, Dr. Sini, sorry, I know you are going to work. I
Yes.
just wanted you to throw a little bit light on that S bar 2 on reporting. The S bar 2. You talked about the situation awareness, the background. The those tools are very clear to me. The A and the arrow, the reporting and the assessment. How do you make that assessment for
Okay.
that? Yeah, for it
For
to
the
be a
S.
complete tool of
Okay.
yeah
Okay.
reporting. Mm.
All right. Before I speak about that, I just saw some questions in the chat. So I think Josephine asked if you need to prioritize from beginning or in the last 1 minute. So it's better you prioritize as you are handling each case, because if you want to wait till the last minute, what if your time is up and you have not prioritized any of them? So I think I think somebody answered you. So as you go case by case, just mention the priority, whether it's urgent or non-urgent. Okay, if you not have time, you might just summarize when you are finished all the cases and just to summarize again. Okay. So for this SBAR 2, Majorly, it's just like a tool that is used in, can be used in different settings when you're handing over, when you're talking about just talking about patients generally. And let me just look for an example. So, like we know, is situation, background, assessment, and then recommendation. So, like I said earlier, so situation is what is the current situation of that patient. Okay, so that's just what it means. So if you look at this case that they have given now, 31-year-old previous CS or placenta previa. So instead of reading everything that, okay, in the first room, I have a gravida 2 para 1, 39 at 39 weeks, who is 31-year-old, So instead of reading all of that, it like summarize the case for you better. So if you say what is the situation, okay, so the situation is rupture, spontaneous rupture of membrane. So this is a case of spontaneous rupture of membrane in a gravida 2 para. So now background. So now what is the background? The patients themselves. So the background can mean different things depending on the scenario. So if you look at the question, so it could be that, okay, previous CS, it could be if it's a station that they tell you is hypertensive or diabetic. If you think that that is related to what you are dealing with. Let's say a patient whose situation is that she's bleeding per vaginum, okay? She's having APH, and from the information they gave you is that the woman is hypertensive, is chronic hypertensive with uncontrolled BP. So that's a very important background to to the patient situation. Is it making sense, Dr. Tete? So
Yeah,
it
it is. It is.
is a case of antepartum hemorrhage on a background or in a you can say the age or gestational age, 39 weeks GA with chronic hypertension, something like that. So assessment usually is from the examination findings. What have you found when you assess the patient? So let's say a woman who has let's say this rupture of membrane tool that we are using. So if this patient is febrile, for example, so on assessment, the woman is febrile, 39 degrees, she's tachycardic, So you're having like, okay, you're saying that maybe this woman has chorioamnionitis already. Okay. Then the recommendation. So what are you going to do? But if for labor ward, you will not talk about recommendation straight up, because now you have to once you have mentioned the assessment, then you now need to prioritize, and then who are you sending, and before you now talk about recommendation. Recommendation is just what will be done, what you think should be done for the patient. Okay, does it make sense?
Of course, you do. You do.
All right.
Yes.
Okay, thank you everyone, thank you all for attending today. I think we'll just find some other time to. I'm sure if you practice more of these stations, with time, we are going to get better, and they will be able to confidently deal with all the stations at a go. We just need to practice it more. Now that we have done all of this, you could maybe record on your own, or if you have a study buddy, just like practice it again and make sure that you do it in 10 minutes. So, and that way in exam, you'll be confident, and it will just be like a bonus. You know that out of the 14 stations, you have one that you are very confident at and you can easily deal with. Okay.
Okay,
All right.
thank you.
Yeah.
Thank you
Thank
very
you,
much.
everyone.
Yeah.
We
Thank you so much
appreciate it.
Thank
for
you
having
very
me.
much
Thank
for the
you.
time.
Thank you.
Yeah. All right. Bye bye.